Welcome back, everyone, to another episode of the Vitality Code podcast. I'm one of your hosts, Dr. Jason Farah, alongside my brother and esteemed colleague, well-bearded male individual, Dr. Jeffrey Farah in Tallahassee, Florida. I'm in Myrtle Beach. Welcome back, Jeff.
Good to see you, my man. Good to see you.
So when we think about from resolutions to results, and we've talked about, we're not looking at gimmicky, short biohacks. We're looking at just trying to be smart about our own physiology, improve that, and tap into the resources that we have. We talked about GLP drugs and using our own physiology to enhance weight loss and get ourselves to kind of overhaul our metabolic machinery. We've not talked a lot about the details of how to administer that hormone therapy, and there's a lot of different ways to do it: creams, injections, pellets. Something that's been on the market it's been on the horizon for a long time, and people have tried over the years for a long time, is oral androgens, oral testosterone preparations. Of course, there's the famous or infamous 17 alkylated esters. I'm sure if I'm not saying that correctly, but basically the steroid structure, and then where you're placing carbons so that the liver can't chew it up in first pass metabolism. Those things like Winstrol, Dianabol, but of course they have liver toxicity. Liver can't chew them up, but then the liver gets damaged in the process. And so those have little to no therapeutic use in the medical world, of course. But I hear there's a new preparation on the horizon that you're excited about and want to inform us and tell us all about.
I'm intrigued.
You seem pretty excited about it. Intrigued.
I'm interested. I'm gonna try. Yeah. So the trade name is Kizatrex.
Kizatrex.
I believe I'm saying that correctly. It's testosterone udecanoate. Is the testosterone, right? It's cypionate, enanthate, propionate. Those are the ones that we've probably commonly heard of in the injection format. So this one
is a really long ester.
Yeah.
Long half-life in the human body. Okay.
And this company is made an oral form of it that they say bypasses first pass metabolism.
One second, let me stop you. So this is not bioidentical hormone. This is synthetic hormone, correct?
Yes, yeah. I always
biochemical structure is not exactly like testosterone. Okay, so because it's got the chemical
not a pellet. Yeah,
undeconated.
Okay. There. Yep. And so oral is always, like you said, been sort of a no-go for everybody because it's going to damage your liver. I don't generally recommend people do it. I don't do it in my clinic. However, this one
and it's not been clinically relevant in the sense that it's hard to raise levels if you're chewing it all up in the liver first.
Right, and it's not even necessary. Like you said in previous podcasts, like you don't even need to do it. So why are you doing it if it's then it has the potential all these negative side effects? So a patient actually a while back brought this up to me, and so I dug into it and researched it a little bit. It's Marius Pharmaceuticals, I believe, is the company. Got no affiliation. I don't know them. I just heard a little talk from them. And their product is Kizatrex, and they are claiming, and they're saying that theirs is oral, but does not go through typical absorption and bypasses first pass metabolism, and it gets absorbed through the lymphatic system. And I'm going to just claim ignorance, and you're probably a little more knowledgeable in that, but it gets uptaken through the lymphatic system. High-fat meal is therefore better for absorption to help with this.
So let's pause there because this is kind of right up my alley as a general surgeon. Yes, I think that's a good concept, and there probably is some truth to that. So I'm actually not coming out with guns blazing like you might have thought I would be. Here's a good model that we have for it, right? Micronized progesterone dissolved in olive oil. The progesterone itself stimulates bile acid secretion from the gallbladder if you have an intact gallbladder. So this is going to be interesting, right? So does the person have gastrointestinal surgery? Do they have a gallbladder? If they don't, they're releasing bile acid all the time. So maybe it's a it's not even something we need to talk about. Yeah. But and then do they have the same configuration of GI tract? So are there people out there that you might be using this on that have had gastrointestinal bypass surgery, those kind of things? That's a minority of those people that are probably coming to your clinic. But nonetheless, so in the case of progesterone self-stimulates bile acid secretion. It's dissolved in olive oil. The fatty, it's kind of almost self-emulsifying, so mixing with the fat. The fat in itself will stimulate the absorption that we know with free fatty acids in the stomach happens, and that is you form these micelles, micelle, micelles, and these fatty acid groups that take free fatty acids especially like triglycerides and things like that, and they absorbed right into the small intestinal lymphatics, bypassing the liver and going right into the bloodstream via the lymphatics first. So stopping off the lymphatics, then from the lymphatics into the bloodstream. This is what Kizatrex is telling us.
That's a great science lesson for us. Thank you for that. I'm going to steal some of that from my patients.
Okay, so I'm on their website.
Okay.
Since we got and it's saying yes, designed to utilize lymphatic absorption, which we just talked about, to bypass first pass, and they utilize a self-emulsifying drug delivery system with phytosterol esters, especially
nice little
with
acronym for that.
A fatty meal. Yeah, SEDDS, self-emulsifying drug delivery system. In the case of emulsification, that's a known physiologic process, and we use it all the time. Soap, I mean, that's a common emulsifier. But anyways, when you take it with food, especially with a little bit of fat, you're going to stimulate bile acid secretion, cholecystokinin release, gallbladder. So it'll be interesting. Through that, you get so much like micronized progesterone. So maybe there is something here. So that's what they're saying. How many times a day do you got to take this stuff?
That's the key. You got to take it twice a day. You have a really, I guess, short action on this. And so you're going to achieve peak levels around 3 hours, 2 to 3 hours, I believe. If I looked at the actual data, I think the peak was right at around 3 hours or coming up to 3 hours.
Yes, 3 to 4 hours. I'm looking at it right now.
Yeah. And so if, they were stressing it for the physicians, if you're testing whether or not the patient's reaching a therapeutic level, you need to make sure you time your blood draws. I guess that's important, but if they felt great and they were taking the testosterone and it relieved all their symptoms, and their tests only got to X level, then I don't know that I would, worry too much about that. You probably don't want to test in a trough, which is, you got this, now you're going to make it a little bit harder to pull labs and tech actual levels, and everybody wants another level. So, but you take an AM and a PM dose, because of that short action window, which, I don't trust anybody. They touted it as a positive, right? This was a positive thing that you had this rhythm to your testosterone. They sold it as a more actually mirroring the natural rhythms of your testosterone, because they said, it's really unnatural. Yeah. It's really unnatural to take a giant bolus of your testosterone every week. That's not what your body does. And, maybe with pellets, it's just a constant level, and that's not how your body works. And so the urologist, who is, I don't know how he's involved with the company, but he's involved. I think it's like the president of, well, yeah, I know he's monetarily involved. I don't know if he was a founder or a hire or what, but, he talked about the definition of bioidentical being, maybe we should rethink that, because bioidentical could mean how it more mimics the body's natural production of testosterone. But that was their touting, and you got to kind of turn a negative into a positive. You could say it's negative to take a pill twice a day, but they kind of turned it into a positive. So I don't know. What are your thoughts on that with the peaks and troughs throughout the day? You have any initial? And I know you didn't really have time to think about this, and I didn't tell you what we were going to talk about. But
this is something we talk about all the time anyway. I don't know. I think I hate to be closed-minded about this, because I've noticed, in life in general, there's always, the only constant is change. I think the dogmatic part of me initially is resistant to it, but I want to be open to it to see if it works. A couple of little things that I saw on the website in their study, I don't know if this is peer review published, but data, because they don't really lay it out here, but it's an open label clinical study. So it's just an open label clinical study. And there was 139 men with low testosterone. 88%, not 100%, but 88% achieved an average of 222 to 800 nanograms per deciliter at day 90. So
yeah, underwhelming.
Underwhelming, because it wasn't, 600 to 1,000 or 800 to 1,000. I know for a fact.
What was their dosing in that one? Because in the talk that they gave, he's like, just go to your top line dose. And here's what I do with everybody. I go to 400 milligrams.
Good point.
Yeah, I don't remember what they had.
They go up to 96% effective. Well, pellets, in my estimation, are 100% effective. So
are injectives.
Yeah, exactly.
If that's raising your testosterone, injections and pellets are 100%. Mm-hmm. I'm going to raise it.
They put people on a 6-month study. By day 90, So 3 months, and then they don't talk about before that either. I mean, what's happening before that? Are people going to wait around for 3 months to feel better? And if they feel better, are they going to feel better at a range of 222 to 800? I don't know.
And looking at the actual value, man, if you pull a peak draw, you're going to get down to the original starting baseline, and that's in intraday, like in the day. You know, if you pull it 3 hours post or 6 hours post, you're back down to baseline. So I imagine that's hard. I hope they control for that in the study, but we don't really have the data on that. I think the thing that got me really
I worry about the peaks and
interested-
troughs too, because your protein synthesis will drop, the vascular benefits will drop. Although they do when you're young too. These diurnal variations are natural when you're young. Diurnal variations tend to go away when you're older, but maybe that's a problem. Maybe that's not. I mean, that's.
Yeah.
So I don't know.
I don't know either. I don't see a giant like negative from it. Like it's going to cause a problem. It may not be optimal, but I don't. I think
it's probably pretty safe. Yeah.
The thing that I saw that kind of struck me as interesting, if it's true, was they had some data that they didn't get complete suppression of their FSH, LH levels with their product, and that was like, because that is a problem. Some guys, like it's not uncommon to have a 20-something-year-old guy come into the clinic with a testosterone in the 200s. It's I don't know if it's just selection bias or it's just everybody, but I'm pretty sure it's selection bias because you don't come in here if you're feeling great. But if there was a product that maybe did a better protective of their FSH, LH for a 20-something-year-old, then I think that maybe can get me a little excited about it. If we can maintain, it's going to lower the sperm count for sure. It shows some suppression, but not complete suppression of their FSH levels. But maybe a little more effective if you combine that with a Clomid, or an HCG. You're getting the benefit of the testosterone without complete suppression of your FSH, and then you come the Clomid, the HCG to kind of upregulate on that side, and you might get a better, smoother. We even talked about, like, I've kind of brainstormed, I don't know if, just sort of hearing about this for the first time, but like, what if you did a small track of pellets to reduce the soreness as my baseline, and then maybe adding the Kizatrex on top of that? I don't know. I think I'm just open to thinking and learning and looking at it a little further and getting some data on it. I'm going to potentially try it myself, and then there's the cost. This was interesting. They said the Marius Pharmaceuticals, and I don't know what their relationship to the Udecanoate, if they have a exclusive patent on it or just multiple pharmacies make it, but they're not going commercial pharmacy at all.
Yeah.
They're going to go to compound pharmacies only, and it's going to be a cash basis only. So the one script I wrote for this, they went to CVS, and the CVS told them they couldn't get it. And now I understand why, because they according to them, they're not selling it to CVS's, and they're not selling it to the Walgreens of the world. They're not seeking any insurance. They're going cash only, going to the compound pharmacy.
I wonder why they would go
only.
through compounded pharmacies because the compounded pharmacy is not going to make it. Marius Pharmaceuticals is making it. So why would you go through a compound? It's kind of interesting.
I don't know. And I don't know if Marius Pharmaceuticals just owns the right to it and they're letting the compound pharmacies make it for them. I obviously that talk was not.
I don't think so. I think looking at the structure of the pill with all the things that are in the shell, even the shell, like the titanium dioxide and the sorbitol and there was a couple of ingredients.
You don't think it's being made by?
I don't think they're making compounding, because compounding.
Maybe they're using the compound pharmacies as their distribution market, right? Because the compound pharmacies have a much more, are in touch with the cash testosterone market physician much more than maybe Marius was having a hard time getting into market.
Perhaps.
Maybe just sat on the shelf for years and nobody wanted to touch it because they just couldn't get the word out.
Be interesting.
I don't know. I don't have any connection to any of them. I don't even use the compound pharmacy.
It's self-emulsifying, and it's dissolved in phytosterol esters. So it's not a powder that you can put into a capsule, because gelatin capsules, compounders use all the time. They just fill them, I don't know if they machine press them or close them themselves with their finger. I don't know how they do that, but this is a sealed capsule around a liquid. So you got to be machine pressed somehow, so right. I don't, that's an interesting thing too, is how are they going to get them out to, or why are they going through compounding pharmacies when there's no compounding that's going on? That's a question. So if you go down to the bottom of the webpage here, these are not peer-reviewed journal articles. You're right. There's data on file. It says data on file in Raleigh, North Carolina at Marius Pharmaceuticals. So it'll be interesting to see dig into the data a little bit more. But and you're right. The dosing ranges from 200 daily to 400 twice a day. I see that. So maybe if you're on the higher dosing side, but again, the highest number that they tout is 800, and that's a respectable testosterone, and a lot of guys will get a lot of benefit from that, and there'll be a lot of amelioration of symptoms at that level. Interestingly, though, when you look at the N equals 139 study, it's 100. In the graph they show the diurnal variation. The peaks here are like around 600, maybe 650.
Yeah, I don't know what dose they did in that study. I can't remember from the talk. It would be interesting. But I remember him saying that the urologist that they hired or that works with them or whatever, he goes straight to the top dose.
I would imagine. I would say the same thing.
It frustrated me a little bit, too, when I was like, well, then why do you make a 100 milligram capsule?
Right.
That's 4 pills twice a day. The pricing was the same for the 100, 150, and 200 capsule, I believe. So, like, why? Maybe it just gets huge. I don't even know what they look like. Maybe it's a giant capsule at 400 milligrams. But why not make a 400 milligram capsule?
Here's another question. If you're saying that the guy, great, I understand the concept of it, give them some medicine, get some real impact. But that also is saying that everybody that comes in to your clinic has the same volume of distribution, which is not true. I've got guys that are literally 6'7", literally 350, 360 pounds.
Yeah, what do you have to take?
It's bizarre.
12
I have
pills?
a few of those. Yeah, I know, right? And then I've got some that are, 5'5" and 180 or 160 pounds. So I'm a little bit suspect about the ability to individualize it. But again, I want to be open to it and see. I know a 6 foot, 205 pound guy in Tallahassee, Florida. We can
198. Thank you very much.
Okay, 198.
I hit 205. That was my peak. I had to reel it back in.
Yeah. Too many cookies. Too many.
I'll kill it.
Was it Christmas? What was it? What was the?
It was the holidays, man. From Halloween to New Year's. Just blew it out. It was like a blur of debauchery and food and poor sleep and travel and kids parties and office parties.
Yeah.
Yeah. So I don't know. I mean, I think there's something there. I do so terrible with injections that I'm just like, I hate those things. I know they work great, and I'm jealous of the guys they work for. I'm just such a weird system in that regard. If maybe, they're saying that the peaks and troughs, actually, they're surmising help lower the hemoglobin hematocrit to elevations, drop the drops in FSLH, maybe estrogen production is less. And I was like, estrogen, that's me. I'm a huge estrogen guy.
That's true.
And so...
Yeah, in their study, it was interesting. They tout that there was not a single person who had to stop due to erythrocytosis.
Yep.
Doesn't mean that there wasn't, because there was a mean increase in hemoglobin, but it was small. But nobody had to stop.
Yeah, it was small.
So, but then again, nobody got up to over 800 either. So I know.
Right. So it'd be interesting. I thought maybe I could, potentially do a low dose of pellets and then add this on top. I don't know how I think about that. I got to mold that over a little more. And what am I trying to achieve? And what does that do? And does it actually work? What I think it's going to do off the top of my head, But I just thought this was interesting, and I think it's interesting enough for me that I'm going to try it just so I can speak. At the very least, I can speak educatedly. I mean, just doing this little, I won't even call it a deep dive, this little dive in the shallow pool of this will help me explain it to a patient, because when he brought it to me, I was not familiar with it. So I can at least say, yeah, I've talked to them. I've heard their spiel. I've looked at the data. I've looked at their studies they've run, and here's the pros and cons. And let's make a decision for you.
Do you have a lot of people that come in and say, "Boy, I sure wish there was some other way to do this"?
Why do you have to be Debbie Downer to my? No, I do not. I don't have a lot of people.
Don't ruin this for me. Don't ruin this for me.
I don't have a lot of people who are upset with their pellets or injections. I think I have potentially
some.
though.
I have some that say that. I have, especially women. Now here, that's an interesting thing too. If you're not getting
that was my other thought. Yeah,
is women. Women,
Because women do. I have some women who don't want to do pellets, but it's so damn hard to do injections on women that, yes, I did have that thought. I'm like, oh, maybe that 100 milligram one, that little baby one, if a guy doses 800 milligrams and the female doses 100, and you could get the benefit there. I did have that thought too.
that's where I think Kizatrex might be missing the boat a little bit when they just got pictures of guys up here, because I mean, women are already taking progesterone micronized. Golly. And it's so funny. I didn't even think of this. It just popped in my brain, thankfully, serendipitously. But actually, that might be something, that might be an interesting, because
then your cost goes down too, because you're only doing one pill instead of 4. So that's a good bonus for patients too.
Right, because the more you take, the more it's going to cost, obviously.
Yeah.
Is there a significant difference between, like you kind of alluded to it a little bit earlier, but is there, if you take 1 pill versus 4 pills, is it 4 times the cost, or?
Yep.
Yeah.
It's per price pill, a price per pill, and it was the same for every dose. And so, I think I'm going to investigate a little bit. I like the idea for maybe that low dose for women. That would be an interesting one. You probably, if you're going to avoid some of the side effects for men, maybe you would also avoid some of the side effects for women: hair growth, oily skin, acne. Maybe not those constant values. Although I think, I say that out loud, something like pellets, which gives a much more constant elevation of testosterone, gives me less of those side effects than injections, which don't give me. So I don't know that the constant value would influence those.
Potentially. One interesting thing in their study, again, I don't have access to the study, and it's open label, clinical, whatever, and it's kept it in Raleigh. I want to see the study, but they talked about decreasing the SHBG levels and increasing free testosterone, and I have seen that be a bigger problem for women than it is for men. In fact, a lot of I've noticed, I've noticed the efficacy of testosterone therapy for women, in my clinical experience, almost, not unilaterally or categorically, but almost, really is derived on the free testosterone. I cannot correlate the total testosterone at all to the efficacy. And
I would agree.
And you agree? Yeah. So, and I found this the hard way, is making mistakes. And a woman that we increased her testosterone from, I think when she came in, her total was like 12 or 20 or something like that. Had a lot of libido issues and energy issues, fatigue issues, mental clarity issues. Came back at 6 weeks after a pellet insertion. The total testosterone was maybe 125, or maybe it was probably 150, 160. So it was in my 150 to 300 range, which is kind of a benchmark for HRT clinics in general that we see out there. High-fiving, we did it. This is great. She's like, meh, I don't feel anything. And I was like, you don't feel nothing. And I was looking over her labs later after she left, defeated and feeling like crap, and like, And I looked, I was like, look at that. Her free testosterone barely budged. Her SHBG when she started was like 120. I started paying attention to this, and what I've noticed is that it's very crude, and it's not hugely overly insightful, although it is at the same time. But there's 3 groups of women I found. There's low SHBG producers, which I defined, I've seen as low as 5 and around to 30, maybe 35, 40. Then there's like the 60s, 70s, and 80s. That's, I call that group B. And then there's the triple digit ones. And I've seen that as high as, recently I saw a woman 250. It was just unbelievable. Now that woman's an exception. I've actually sent her to an OB. I'm worried she has a granulosa cell tumor from her ovary secreting estrogen. Her estrogen was 600, 700.
I was going to say,
without estrogen therapy. I mean, even off testosterone, we were worried about convert. I mean,
postmenopausal? She wasn't like ovulating at that moment and was that high?
Correct. And very strange. FSH at the 600s was still like 26. I'm like, what is this? Bizarre. Anyway, so maybe there is something else going on, but at any rate, people that are estrogen dominant, I've also noticed that they tend to have higher SHBG. We do know that estrogen induces the liver to produce more sex hormone binding globulin. By the way, it also induces the body to make more thyrotropin. So you'll see a lot of people have subclinical thyroid dysfunction because while their total testosterone may be good, thyroid, their free is not because of thyrotropin. So excess thyrotropin, you get them on testosterone. Together. Yeah, it's very interesting. So at any rate, if this can lower the SHBG while simultaneously giving a modest increase for women, perhaps this is going to be a nice therapeutic advantage for them when they, may not want to use other modalities.
Yeah, it'll be interesting to see how it plays out. But I'm gonna get my doctor to prescribe it. I'm on pellets right now. I just had an insertion not too long ago, so I'll let you know how it goes.
Nice. I will say this: it's probably a heck of a lot better than putting on creams. Good Lord.
Yeah, I don't
Twice
use creams
a day,
anymore.
rubbing creams all over you. Where do you put it?
That's a good point. I don't use creams unless the woman is on them already and wants them continued.
Yeah, that's exactly the same. I'm the same way.
It's going to take you up to 6 months to figure out your dose, and it's going to take you up to 6 months to find out if it's even working. And every time I've done a cream, everyone's like, "Can we just get the show on the road?" Like, let's just do pellets.
Right. Right.
So, yeah.
Kizatrex coming to a hormone clinic near you, and we'll see.
Coming to Tallahassee and Myrtle Beach. Jason's gonna be wearing a Kizatrex shirt next time I see him. I'm like, did you go somewhere, Jason?
I'm gonna get it embroidered on my
sponsored by Marius Pharmaceuticals.
Right. Body by Kizatrex. Yeah. So I guess we'll have to wait. So how long are you going to take it? You going to commit to 90 days?
I'm not committing to anything. And if it's working, I'll do the 90 days. But if I feel like crap, I'm not doing it.
Yeah, well, that'll be.
I'm not waiting 90 days.
Right. So, I mean, are we going to ask patients to wait that long too? I mean,
hell no. That's why I'm doing it first. I'm going to find out. If it takes 90 days, then I'm not doing it.
And here's another thing.
They did that data like. Surely there was a group that did it in a week, a group that did it in 2 weeks, and a group. But to get the majority of guys to get that 96%, they had to stretch it out to 90 days. So I wonder what the efficacy at 4 weeks was. That would be a much more clinically important.
Well, interestingly, 90 days was 88%. End of study was 96.
Oh, jeez. So what's 4 weeks? 20%?
I'm sorry.
I said, what was 4 weeks? 20%?
They didn't really delineate that. They said 90 days, the 3 months. They didn't delineate.
No one's waiting 90 days. Not when injections can work in 12 hours and a pellet can work in 4 days.
Yeah,
so it'll be interesting to see what happens. But I think I was at least initially excited because it has the potential ability to bypass the liver and no damage there potentially. If what they say is correct, again, I don't really trust anybody, so we'll see. I have no reason to distrust them. So
the physiologic principles are at least correct.
Right.
That's good. And
there was a clinic I was training out in, where was I, Colorado, and he said he uses it.
Oh, really?
We didn't get further than that. I just mentioned it. I was like, oh, yeah, I'm going to go here and talk to him.
Well, you were training him for pellets, though.
I was training for pellets. He uses it as a testosterone replacement men's clinic, and he uses it as an option. So we'll see. Again, I think it has potential for the females, like you said. Maybe another option to look at. Always open to expanding the horizon a little bit.
Well, let's see. You're going to come back to us with your results. And here's 100%. The other thing. You got to get down to a baseline. So
no way.
Yeah. So are the pellets on, or are you starting at like 400 or 500?
Yeah, I'm starting at 700. How do we know? Where I'm starting at.
Where?
I'm starting it at 700. That's when I get my pellets. Is when I'm at 700.
Oh, yeah, that's interesting. So you've noticed that's the level you start to feel really crummy, I guess, per se.
Yep, that's when I notice it starts to drop. So I get my pellets when I'm about 700, which for me is about 12-ish, 13-ish weeks.
Interesting.
So that's when I'm going to start the Kizatrex.
Okay, so how long are we going to have to wait for these results? When are you drawing a line in the sand?
I just got my pellets, probably in a week plus. So we got another 3 months before.
Interesting.
All right, we're on the
we're like two
cycling together.
That says right. We're good. That's interesting. So we're looking at February, March. April. We're looking at May, sometime in May. That's right, the 22nd. We're gonna wait. What's today? We're recording this on
21st.
Your birthday it is. Oh, man, happy birthday!
I'll take the first one.
That's right, on air. We want to take the first one on air. Oh my gosh! All right,
I feel so good.
I know, instantaneously.
They were talking about some dosing changes. Like you got to time your dose right, so you don't want to take your last dose before bed, so that so there's a little bit of like logistics that you probably have to work through that I don't know that patients want to. Like when do you take your first dose? When do you take your second dose? Because that peak is you got to time that 3 hour peak, 3 to 4 hour peak. So we'll see.
I'll tell you what, on Valentine's Day, I'm taking that second one. We'll see. We'll get home from the restaurant at 9:30 p.m. 5 p.m. baby. I'm taking that, so I'm hitting my stride when we get home from the
right at 8 or 9 o'clock.
Putting on the I don't know what kind of music. The baby making music. Got my peak serum
Don't you do
testosterone.
that. Don't make any more, dear God.
Got enough kids over here. They're running
There's
wild.
parents running around. You're going to be
All
that
right,
old
my
dad, man.
It was a good talk. Kizatrex or Kizatrash. We're gonna see. What's
That's the episode title. We're working on our
That's a working
social
title.
bombastic titles and stuff so we can
That's
get
right,
picked up,
Hook.
viral. Yeah.
You want to go higher?
All right, bud. Good
We'll
talking
see you
to
next
man.
time. All right.
All right.